Hello everyone, my name is Abdullah Abbasi. I'm one of the GI fellows from Royal Wolverhampton NHS Trust. I'm grateful for IBD Club and South Asian IBD Alliance to give me this opportunity to present this in the virtual journal club. So the study we are going to discuss briefly today is predictors of anti-TNF treatment failure in anti-TNF-naive patients with active luminal Crohn disease. This was published in 2019 in Lancet. And just to give you a bit of background, we all know that infliximab and adalimumab are very effective in treating Crohn disease, and they improve mucosal healing, reduce hospitalization, surgeries, and hence improve quality of life. However, treatment failure is common, and 10 to 40% of patients do not respond to induction therapy, and there are quite high numbers for people who have adverse effect or lose to response. So the aim of the study was to look at various factors to predict which of the patients would actually have loss of response or would not respond to anti-TNF treatment. So to go to the methodology of the study, this was a UK-wide multi-center study, and more than 120 patients were involved, quite an extensive eligibility criteria, and most patients who have active Crohn disease were included, and patients who had previous exposure or contraindicated to anti-TNF were excluded. But few definitions before we go on, and they assessed the disease activity at two levels. One was at week 14, where they saw initial primary response or treatment response, and the other was week 54, where they assessed remission. So the initial week 14, if people responded to the treatment with improvement of CRP or HPI score, then they were primary responders, and if they did not, then they were primary non-responders, and if only one of those criteria were met, then that's a gray zone. Similarly, for remission, if the CRP had improved or the HPI score had improved, and there was no ongoing requirement for steroid, then those patients were considered in remission. But if these criteria were not met, they were in non-remission, or if they weren't steroids or immunomodulators, they had loss of response, but that was after week 14. So you can see the total number of patients that were assessed in week 14 and week 54, quite a big cohort. In total, at the end of the study, there were 770 patients in infliximab arm and 441 in adalimumab arm. So just to discuss their results, the characters of the disease, the patient characters in both those groups were quite different. At the start of the study, patients in anti-TNF group were more in infliximab group were more unwell, and they had more use of immunomodulators as well. However, at the end of week 14, there were 21.9% patients in infliximab group who were primary non-responders as compared to 26.8% in adalimumab group. And there were 60.9 patients at the end of week 54 who were in non-remission as compared to 66.9% in adalimumab group. And this is one of the key slides from the paper. This is a univariate analysis that is done regarding primary non-response at week 14. And as you can see, in both adalimumab and infliximab, the most important and significant result is drug level as well as antibody concentration. So if you have a high drug concentration in your body and low level of antibody concentration, then you are more likely to respond to treatment. And this is true for infliximab as well as adalimumab. A couple of other interesting things, as you can see with age, if the age was on the higher side in infliximab group, then they are more likely not to respond. They were primary non-responders. And if their weight was high in adalimumab group, then they were less likely to respond and would primarily be non-responders. And this is a univariate analysis looking at week 54. And again, you can very consistently see that whatever was happening at week 14, which is the drug concentration and antibody level, persist at week 54 as well. So if they had good drug levels and low antibody levels at week 14, then they were more likely to be in remission. But if that was not the case, then they were likely to be in non-remission. And what they noticed is the optimal drug level at week 14 was 7 milligrams per liter for infliximab and 12 milligrams per liter for adalimumab. The other key factors that they noticed was obesity at baseline was associated with non-remission at week 54 in patients with adalimumab, and smoking at baseline and no previous history of perineal disease was associated with poor outcomes at week 54 for adalimumab as well. There were quite significant side effects in both these medications, but they were pretty consistent with the previous studies. But what was reassuring is that use of immunomodulator at the same time was not associated with any increased risk of infection. So some of the key points is, as we mentioned before, that week 14 was the key. And when the patients are assessed at week 14, if they do not have enough drug levels, then that might be an opportunity to intensify the dose of medication. However, if they have enough drug levels at week 14, then this might be an opportunity to switch them out of class. And the use of immunomodulator, certainly with the infliximab group, seemed to be quite effective. There are certain limitations of the study. All the assessment of the disease was done through biochemical markers rather than endoscopy, but those markers are quite reliable. And since one of the markers used was CRP, which is slightly higher in obesity, it's quite possible that it could have been slightly overestimated in that group. However, this is one of the largest prospective study for anti-TNF patients. They identify major modifiable risk factor and certainly some key elements that we can all use in our practice. So thank you very much for listening, and we hope you will join us in the discussion on Twitter as well. Thank you.